You won't recognise the liver, I can promise that. And it's not your liver. And hopefully it's a liver that you won't need there in the future. What I'm going to talk about is warm perfusion, which is, I'll explain what that's all about, but I learned a lot about warm perfusion going to Oxford and Leicester. This chap in the middle here is Professor Peter Friend, who some of you may know is one of the big gurus of warm liver perfusion. And this was back 4 years ago, and then with the help of all of these people on the front, including your good selves, we have managed to get a liver perfusion program set up in Newcastle. So Live Life, Give Life for a charity, national charity, all organ transplantations. They've got a great website. And if you've got a free moment, go and look at the Orgamites. You'll like the Orgamites. LIVErNORTH, obviously. NIHR, the National Institutes of Health Research. Royal College of Surgeons. The Trust has put some money into this as well, as has the university. And you have to ask, well, why is everyone putting money into this? What's the matter with the old box that we used to take, and we still do take the majority of livers from the donor to the recipient in a box, filled with ice, and inside the box is the liver. We take the liver out of the box and then it's ready for transplant. But now we're moving more on to this kind of setup, which is a pump, drips, a warmer and an oxygenator to try and get the liver to produce bile outside of the liver. And the reason is, this is a slightly complicated graph, but the reason is that of all 100% of organs donated, 83% actually end up having a kidney transplant from that donor. Very few of the hearts and lungs are found to be suitable, 6%, 8%. The livers we think are suitable right up to the point they're removed, and then by the time they reach us, a lot of them are unusable. And there's a big loss in organ function in the liver in the period outside the body. So we're trying to cut down on that loss of organs that we can transplant. And particularly with DCD organs, that means donation after circulatory death. As you may be aware, brainstem death is where the donor has sustained a massive head injury or a stroke, and their heart and lungs are still working, but their brain is dead. And an anaesthetist can sign a form saying they are dead. And in that situation, we can take the donor around to the operating theatre and remove the liver just after the heart stops. There's less and less of those donors because we're being safer and safer as a society. You don't get 17-year-olds on motorbikes without crash helmets these days. Everyone's very safe. So more and more it's people in their 50s, 60s, 70s who are donating, having had a life of high blood pressure, smoking, obesity, diabetes, all these things that can affect your organ function. And when they die because their brain is still working but the heart is not capable of functioning correctly. So they're on a machine supporting their heart and lungs. The anaesthetist goes to see the family and says, I'm afraid your loved one is going to die. We don't know when, but their life is meaningless at the moment on the machine. There's no point in carrying on. Please can we switch off the machine? And that's DCD. So they switch off the machine, we wait for the patient to die, and then they become a donor, they're taken round, and the liver's removed when they're cold and blue. And that means that there's a lot of damage during that process. And it's the bile ducts of the liver that sustain that damage. And you can see in these figures, so 27% of DCD organs will have to be retransplanted. That's nearly a third of all DCD liver transplants will have to be retransplanted using current technology. So we're trying to change the technology, improve the outcomes for recipients, for people with liver disease. And against all of this, of course, the age of the donor is getting higher and higher. So back in 2005, only 12 years ago, only 3% of our organ donors were over 70. Now it's 11% in 2015, and the latest figure is 15% of organ donors are in their 70s. So the donors are becoming older, and of course, as you get older, your organs just aren't as good as they were when you were younger. So the size of the donor is also increasing. More and more people are over a BMI, a body mass index of 30, which is when we run into problems with fatty liver disease. And of course, fatty liver disease is You had the talk last month, wasn't it, from about non-alcoholic fatty liver disease, and that's diabetes, and that's the size of people, and it also impacts the high cholesterol on your blood vessels. And I need to stitch the liver in, and the blood vessels need to be able to take the stitches. And so if they're not up to it, we can't transplant the liver. I do say, though, it's not about the registration plate, so there's some very healthy people in their 70s and 80s, and we do use livers. I've transplanted an 85-year-old liver very successfully. But generally speaking, yes, of course, because as the older the car is, the more miles on the clock there are, and the more problems that you're taking from the donor into the recipient. So that's why we're doing it. We want to put the liver on a pump, test it, make sure it produces bile, make sure it works the way it should do, and then I can come and see the recipient and say, we've put the liver on the machine, it looks good. There's a very good chance of success. So although this donor is a little bit older and it's a DCD organ, actually we've tested it and it's successful and it looks good, and therefore you're not going to be one of the 30% of people needing a retransplant within 3 years. So we're trying to increase the number of transplants on the back of that, and reduce, most importantly, reduce the complications for the recipients. Because you want to have a safe transplant if you're needing a transplant. So we talk about this as reconditioning, changing, manipulating, resuscitating the organ. We have to be quite careful about the words we use, because I don't know if there are any lawyers in the audience. As soon as we start saying we're changing something, then the lawyers go, products, you're engineering a product, therefore you become part of product law. And the lawyers, if you're a product lawyer, can get you because you haven't manufactured your product to a satisfactory standard. And so we have to be very careful. Of course, the easiest thing to do is just to say, we're not doing Frankenstein, we're not doing any of this, let's not do anything, let's stay in the cave, let's not come out. But actually, we have to do it. We're not going to do that. We're not going to try and resuscitate the dead. We're not going to try and make Frankenstein here. But it does make some issues about what we can do to livers. So we can change the genetic code, and we can potentially make the liver more susceptible to, or less susceptible to rejection, more susceptible to implantation. So that means that we could potentially take a pig organ and make it into a human organ on one of these pumps. And I suspect that also is the direction of travel. I'm not talking this year, next year, 10 years, but maybe 20 years down the line, that's what we'll be doing. I'll stop by the farm in the morning, we'll pick up a pig, we'll bring it in, put it on a pump, and then we'll take cells from the recipient and we'll pump them into the liver and turn that liver into the recipient's own blood group, own blood type. And then you won't have to take immunosuppression, and you'll have your own liver. We'll bioengineer a new liver for you. And this is the start of that kind of technology. We can't do that in an ice box. We have to put it on a pump. We have to get it live again so we can change it outside of the body. So we are changing the signals within the organ, and potentially we're going to look to decellularize, take away some of the cells and replace it with your own cells. So you get your own transplant. This is like personalized transplant. So you're probably all thinking now, wait a minute, he's talking about a lot of things which are potentially big news and have ethical implications about where our organs go, what do we do with them, who do they belong to. He's going to change them. That's not what I want when I donate an organ, or maybe I don't want an altered organ. So we need to think about this and think about how it works and why it works and where we go with it. But at the moment, this is where we are. We have a machine, we take blood from the blood bank, we have nutrients in drips, we have oxygen going round and round, and we just provide blood at body temperature with oxygen and nutrients to the liver, and it recreates its own proteins outside of the body, and you can measure these proteins, as we'll talk about. But we think the main thing is it's like charging your iPad, plugging it into the mains. We think this is the main way it works, mains way. So when you take the liver out of someone and put it in the cold, it loses energy, it decharges, and you can measure the amount of energy within cells And just as the liver goes into someone, after a period of cold storage, it's on red. Its energy levels are very low. But if we put it on the pump, we charge it up with energy. So when we put it in, it's ready to go. The oxygen, the nutrients mean it's pumped up, ready to go, produce bile straight away, and hopefully the recipient will recover quicker. So that's what we're talking about. Both, does it work, expanding the criteria, the number of livers we can use, but we could also deliver drugs, deliver cells, deliver therapies to the liver, but also I have to keep coming back to the improving recipient outcomes. This is about making things better for patients. So when we started setting up the program in Newcastle, we went out there to see what machines were available, how we could do it. I knew I could do it with machines that were available, but I'll show you now what the problems are. These are all commercial companies. The commercial companies have shareholders, they have investors. Most of them have venture capitalists who have put in huge amounts of money and are looking for big returns on their money. They're not doing this out of the goodness of their heart, and they want to get their money back. So, if you buy the OrganOx machine, even though Peter Friend has pledged his time for free, it's funded by venture capitalists, the machine itself costs £75,000. Each time you use it, it's about £10,000, plus the blood. If you think, at the moment, we get paid by NHS England £60,000 to do a transplant and the first year's medications. It just, financially, we can't make these machines make sense. So we said, well, we can't afford that. TransMedics, American company, £120,000 they want, and they want £30,000 each time you use it. So, no, we're not using that. Thank you very much. Organ Assist is a bit cheaper. It's about £3,000 a go. And we did look at this machine. There was a number of issues with it. And we thought we could potentially come up with something better. Organ Recovery Systems are an American company, and they decided to make an iPad version, basically, lovely. But you pay, again, hundreds of £1,000s for the design. So they all get their equipment, their components from a Dutch company called Medtronic. So we went to Medtronic, this is another one, and we said to Medtronic, could we just buy the components off you? So we bought the components with the help of LIVErNORTH, with the help of your money, and we built a system for, I think it costs £18,000 for the original setup. I'll show you a picture now. And each time we use it, it costs £600. So you can see the kind of margins these companies are looking to make out of the NHS. I'm afraid that's why the NHS is in problems, because it's looked at as a way of getting money quite easily for venture capitalists. So this is all the kind of technical details, but it's basically Medtronic, commercially available equipment, which is used for heart-lung bypass in the trust. We have a wide experience of using it, but all we've done, instead of putting a patient in the setup, I'm just going to go on, is we've got a liver in the setup. So you have a liver in a bowl, and in this case, the perfusion fluid comes out of the liver, goes into a reservoir, goes through an oxygenator, oxygen gets added to it, carbon dioxide gets taken away, and then it's pumped through the liver with its nutrients. And we do it at two temperatures. One is a cold temperature, and one is a warm temperature. And I'll talk about why we do each of these. But that's the equipment your money, our money, has bought. And it sits upstairs ready to go, and we have a team of people who know how to use it. And that's the bowl. That's the liver. Not quite like that.
What was the cheapest part?
Well, exactly. You know, unbelievably, it is the cheapest part, the liver, because people are incredibly generous, and they are donating their organs. And that's the problem here. They're donating their organs, and we're not transplanting. You know, only 28% from that graph. We want to get that other 72%, and that's why we're using this. So, 5.8 degrees, 6 degrees, low temperature. We can provide oxygen. We don't need to use red cells. We can just dissolve the oxygen in the water. There's enough oxygen that goes around, and the cells can replenish their oxygen, their energy stores at that temperature and with that oxygen delivery. The big advantage of cold, of course, is that we're happy in the cold. We know we're not going to damage anything. At 37 degrees at body temperature, if you don't get the oxygen delivery quite right, you can potentially damage the organ. So when we started doing this for patients, we thought, right, we're going to start doing it at cold temperatures. Be safe, show that it works, show that we've got the experience using equipment which is designed for this purpose, but is not marketed for this purpose. So what we've done is a series of clinical transplants, and I'll talk you through, at a cold temperature first. I'm sorry, this will not work. We've got some video here, but I'm afraid I've tried it on the hospital computer and it won't work, and I can't get the thing here to run my laptop. But I will get it sorted out by next week, I hope. So this is a little movie, and I don't think this is going to work as well. Please work. No, it's not going to. But what happens is here is the main vein coming out of the liver, taking the fluid back. And we've managed to get it set up so it replicates how your heart and lungs work. And when you take a deep breath in, you actually suck blood out of your liver, because you generate this pressure, negative pressure in your chest, and it sucks blood out of the liver. And we've managed to recreate that situation, and you can see this lovely pulsation in the liver. Very satisfying from a surgeon's perspective to see what happens in the human body happening outside the human body as well. And the liver goes from looking quite poor in some cases. So these are all DCD transplants we've done. Patients who are on their third, fourth transplant, DCDs all declined by other centres, livers that no use, people saying can't transplant it. We brought the livers up, we put them on the pump, said that they look okay, gone to the recipients and said, we want to use this liver. And we've done 10 transplants to date. All the patients are alive and well. One patient has lost the liver to rejection, nothing to do with the organ preservation. But that patient's been successfully retransplanted and is still alive. So it's almost getting to the stage already within 1 year that some of my more sceptical colleagues are saying, right, we're not doing it unless we can pump the organ. So we're not using that liver unless it gets pumped. Now, if you're a patient waiting for a liver transplant, I'm seeing hopefully most of you in clinic and saying we have this technology, we think it's safe, but we don't know it's effective yet. We've got to be scientific about this. You know, just because something happens once or twice or 3 times or 4 times, it doesn't mean it's going to always happen like this. And we've got to remember, we were doing transplants, high-risk transplants. Derek Mallis was doing high-risk transplants before I was out of nappies, and he was doing it very successfully without this kind of technology. So yes, we have new technology, and yes, it's great, but we haven't shown it's effective yet. So don't, if a surgeon comes to you and goes, it's come in a nice box, it looks great, we're going to try. Don't start thinking, it'll never work, it's not been on the pump. It doesn't make it that way just because I've had 10 good results to start with. But of course, once you start pumping stuff around it, you can start measuring things as well. We've measured this substance called lactate, which is produced by your body. You may have heard athletes at the Olympics talking about lactate build-up in their muscles. Well, your liver's job is to get rid of lactate. So when the sprinters stop and they're breathing hard, it's the liver that's actually removing the lactate. And we've shown that the clinical liver transplants that we've done with the pump, the lactate levels come down very quickly. And actually we've shown that the liver is functioning even in the cold. It's working really well. But you can see, so the DCD, of course, when a patient's heart stops, blood stops moving around their body. And as soon as blood stops moving, it clots. And it clots within the liver. And that's the reason that DCD liver transplants are more risky. Is because you have this problem with clots within the microcirculation within the liver. But of course we pump the liver and we push fluid gently through the liver and we can wash out those clots. And so when it's put back into the recipient, the blood can flow through the organ more easily. That's one of the theories about how it works. ALT is an enzyme that we can measure in the blood of the recipients, and it comes directly from liver cells. When a liver cell dies, ALT is released and it circulates in the body. In these kind of transplants, what you expect to see is a big peak on day 1 after liver transplant, that they release ALT, big volumes of dead liver tissue being put into the circulation, and we can measure that. Normally we would expect to see peaks at 3,000, 4,000 in the first 24 hours. we haven't seen that in all of these high-risk transplants. We had one here who had a bleed and had to go back to the operating theatre, and he had a high ALT, and this patient got a bit dehydrated and got a high ALT, but otherwise the ALT levels have been very low, which suggests to us it's been effective. But again, it's not proof. It's not proof. Longest follow-up 14 months. The bile duct injury, what we call ischemic cholangiopathy, we've seen in one patient, and that's the scan, and you can see a little area there. Normally we would expect to see 20 to 30% of patients, that 30% people needing retransplant. Well, out of this 10 we've only seen one, and that he's still doing fine with that little area in his liver. That's it from another perspective. So warm perfusion, that's when we add RBC, red blood cells, and so we've done that experimentally. And we're at the stage now where we could do it clinically, but we're looking for the right liver. And the trouble is the cold perfusion seems to be working so well, we're thinking, why should we take the risk with warm perfusion if there is a risk? In my own mind I have an idea of the livers that we might benefit from warm perfusion, but it's difficult to articulate this in a talk. We have got permission now from the Trust because we've got to the stage where we can do it, and of course every other centre in the country is doing warm perfusion. So we will do warm perfusion, but I'll talk about the difference. This is Andy McNeil, one of my consultant colleagues, is a radiologist, and he's done these lovely scans using microbubbles of the liver on the back table, and again we've got some great pictures of what happens to the clots. This, I'm afraid, is not going to work, but you can see as the bubbles flood through, this splash of colour through the liver, and at the start there's big gaps in the liver perfusion. The clots are there and that area of liver is not being perfused. But after 4 hours of perfusion, everything changes and the liver is uniformly perfused. And just that 4 hours of perfusion, still not exactly sure how many hours we need to do, but 4 or 6 hours seems to improve the amount of blood going through the liver quite perceptibly. So we've done 6 livers on warm perfusion after a short period of cold storage, and then what we've done with another set of 5 livers is gone, right, what does bad really look like? We don't really know what bad looks like, we've never really tried it, so we've left the livers for another 24 hours in cold storage, and then we've warmed them up in a bucket of warm water for another hour, pushed them to the point where we know it's just totally untransplantable, to see what bad really looks like on the pump. And we get some surprises. Biggest surprise is that it still clears lactate on the pump. So we can't rely on lactate telling us how badly damaged the liver is, because even if it's really, really badly damaged, the lactate still comes down. So that was a really useful exercise for us to see that don't rely on lactate. Other centres do. Birmingham are big fans of lactate, but unfortunately they've run into problems. Bile production though. If we look at the amount of bile that a liver produces, that seems to stop completely. If it's really damaged by the amount of warm time it's had in the donor and the cold time outside, it doesn't produce any bile. So that's something that it makes sense to us as well, that if the liver's not producing bile, it's not a good liver. So I think that's how we're going to assess livers on warm perfusion, how much bile it produces. But what Andy's also shown us is that we can biopsy some of these areas, particularly that area that we've seen, and see how much damage, how much necrosis, as we call it, on the biopsy. So that looks like a good way of assessing the liver as well. So what we've done is we've gone from nothing, no experience at all in the last 3 years, to doing 10 transplants using cold perfusion. We're at the stage we're going to bring in warm perfusion, and we're also at the stage where we can effectively, I think, discriminate between cold and warm. And more importantly, we've done it in a way that is cost effective and that the NHS can sustainably afford. What we need now is to spread the message and to get more people interested, and of course there is a financial commitment. Taking this kind of technology forward does need more money. So I've gone to the National Institutes of Health Research, to their efficacy mechanism evaluation programme. Newcastle are leading, Cambridge, Edinburgh, King's have been impressed by what we've done. Leeds as well has asked to be involved, but I don't think we need the numbers. And what I want to do is warm perfusion versus cold perfusion. Do we need the warm perfusion? Can we not just get away with cold perfusion? But this is going to be about improving outcomes. What I want to see is, can we make life better for the recipients? Can I make the 3-week hospital stay down to 1 week? Can I get you out of hospital well quicker with a better functioning liver? So that's what we're going to do in a cost-effective way. Of course, I'm just waiting to hear back from the reviewers whether we can get this funded. This kind of technology isn't cheap. Research isn't cheap. It's going to cost us about £2 million to run this trial for 135 patients nationally. But hopefully, in the long run, we'll save hundreds of thousands of pounds, because these patients will be better, and they'll go back to work, and they'll have a productive life. And this is what research costs, unfortunately, these days. Everything costs. The one thing I'm annoyed about is they won't let us use our machine. Because they say it hasn't got the right approvals. Even though we've used it, we need to take it to the MHRA, we need to take it to CE marking, all this kind of stuff. So we're going to have to use the organ assist machine. But there we are. We can still use it in-house. We have approval from the trust's happy. We can still use it here. Hopefully the NHS will wake up and say, yeah, actually, let's just use the cheaper machine. But thank you. So this is what we're doing on behalf of you guys, and thank you for your support. And that's the team of people. This is the guy who's done most of the work, Rodrigo, I should say. Thank you very much.
Very interesting.